Hello, this is Jon Rosenburg, Neurocritical Care Fellow at Columbia and Cornell Medical Centers. Today I'll be talking with Dr. Simard, Professor of Neurosurgery at the University of Maryland, a renowned vascular neurosurgeon and expert in cerebral edema, about his recent article published in Neurosurgery, Low-Dose Intravenous Heparin Infusion After Aneurysmal Subarachnoid Hemorrhage is Associated with Decreased Risk of Delayed Neurological Deficit and Cerebral Infarction. This paper is in essence a single-center retrospective cohort study examining outcomes of aneurysmal subarachnoid hemorrhage patients who received either low-dose intravenous heparin infusion or traditional heparin sub-Q for DVT prophylaxis. Dr. Simard, welcome to the NCS podcast.
Thank you very much. I'm very happy to be here. Thanks.
This is a very important paper with the potential to influence our routine care of patients with aneurysmal subarachnoid hemorrhage. Can you discuss the rationale and inspiration behind the study?
It's kind of an interesting story, John. It goes back almost 2 decades, and it all started with a patient who is one of these snowbirds who was traveling from Florida, Deerfield, Florida, going north, passing through Baltimore, and she was headed. She and her husband were headed north to, I believe, in New York or New Jersey. And she suffered a subarachnoid hemorrhage, and so they stopped here in Baltimore. And the patient at that time had an aneurysm that I clipped, and she did well for a couple of days, as so often happens. And then she began deteriorating, and we made a diagnosis of vasospasm, and we started. But the problem was she developed a carotid dissection from the angiogram that was used to diagnose the vasospasm. And so we used heparin in her to treat the dissection, and with that treatment, her vasospasm eased, and she ended up doing well and went home. But that triggered something, obviously. Wow. And I began to study this. And again, this is 2 decades ago. I began studying this, and we've learned a lot since then. Most importantly, that it's not a great treatment after vasospasm has begun, but it can be very helpful when it's used prophylactically. One of the things that we have found over the years is that these patients do remarkably well from a cognitive perspective. And that's something that didn't come across particularly well in this article that we're referring to, because we didn't really measure it in all of these patients. But over the years, I've really been amazed when I see these patients come back into my office for their 6-week or 8-week checkup after hospitalization, school teachers going back to teach school, computer programmers going back to their work in IT, all of these high-level functioning people, not everybody, but certainly a larger proportion than what I had been used to before I started doing this, doing well. So it started with one lady who had a serendipitous episode that taught us something, and we studied it. We studied it by reviewing the literature, studied it by trying this whole concept out in a rat model, which was published a few years ago, and graduated to understand it better in humans. Interesting story.
In reviewing your paper and the references cited therein, it was interesting for me to learn about the use of heparins as anti-inflammatory agents, how the large chain heparins and their multiple binding sites are used to basically stabilize the blood-brain barrier and have anti-inflammatory properties.
Yeah, that's an interesting aspect of heparin. This is something that really emerged when I reviewed the extensive literature on heparin. There are papers in other fields of medicine, burn medicine, for example, where patients are at high risk for inflammatory responses from the burn injury, intestinal issues, a number of other areas of medicine outside of neurosurgery where heparin has been developed and used as an anti-inflammatory agent. And it's all related to the fact that it's a highly, highly charged molecule, negatively charged, And so what does is it binds and inactivates many cytokines and chemokines and other things. So it acts almost as a multifaceted anti-inflammatory mechanism rather than a precisely targeted anti-inflammatory, like many of the drugs that we think about.
Oh, fascinating. Can you tell us briefly about the low-dose intravenous heparin protocol infusion that you used in this study and how you came up with a pharmacological endpoint such as PTT less than 45 for the patients?
Well, I'll start by responding to the last part. First and foremost, anything we do, of course, has to be safe. And the patients that we had started to treat and study were all patients that I had operated on. That's how all of this started. And it was in the earlier days of endovascular treatment, of course. And of course, starting somebody on heparin right after surgery, most people would say, I was a little crazy. And some did say that. But we ended up coming up with a protocol. We're starting drug 12 hours after the procedure ended. And we have to remind ourselves that heparin, of course, is not thrombolytic. It prevents clotting, but it's not thrombolytic, so it's not going to undo any of the, small thrombi that are in the skin edges or at the brain edges where you've treated the patient surgically. So, and in terms of the dose, I started out with a lower dose, but I deliberately accelerated it. We started at a low dose at 12 hours and then waited 12 more hours and bumped the dose up and then waited another 12 hours and bumped the dose up. Mm-hmm. And all of this was, again, predicated on safety. And at each step, looking at the PTT, which is what we had easy access to over the years for measuring the anticoagulant effect of the heparin. So safety has been key. Keeping the PTT below 45, we thought was a reasonable target, and we've been able to achieve that with the dosing regimen that we published.
And for the listeners, in essence, PTT patients in the low-dose intravenous heparin infusion, they had a heparin infusion started at a low dose 12 hours after securing the aneurysm, and that dose was gently was monitored every 6 hours and up titrated, maintaining though a PTT less than 45.
Yeah, exactly.
The data in the study was analyzed by two statistical models, a classic multivariable linear regression and a propensity score matching by inverse probability treatment weight. Can you discuss the rationale behind using a propensity score model and how it influences the conclusions one can draw between exposure and outcome in a retrospective study?
Well, this was the brainchild of the statistician who was also on the paper, Beatrice. She's brilliant. She did an absolutely outstanding job. And in terms of propensity score analysis, I'm sure that many of the listeners are familiar with this approach to analyzing patient-related data. But most of us who are familiar with this concept utilize it as a way to, I'll put this in air quotes, sort patients who fit a certain propensity score and, again, air quotes, kick out or remove or disregard patients that don't fit, right? So that you have two matched cohorts. The beauty of the way that this analysis was done was by weighing the data by either the inverse of the propensity score or 1 minus, depending on which group it was. And that allowed us to use all of the data. So none of the data were excluded, which of course improves the power and therefore the conclusion, makes it more broadly applicable to all of the patients that were included. And that ended up giving us a result that essentially matched the more conventional analytical methods in utilizing statistics that people are more familiar with. So,
with your model, you were able to correct for a lot of basically the imbalances of the demographic imbalances were corrected for, and despite that, you still showed similar. We'll get into. But you still showed similar results between the unadjusted and adjusted model.
But interestingly enough, if I may say, in terms of the imbalances, it was a matter of the patients who were receiving the intravenous heparin really in some ways being worse off to begin with, right? So if you look at the unadjusted result on certain things in terms of severity of the hemorrhage or severity of their neurologic presentation or the incidence of vasospasm, the ones receiving the heparin were worse. So adjusted things, what I'll say, I mean, this was maybe not the right way to phrase it, but sort of in favor of the patients not getting the drug, right?
Very well said. And we'll touch on that point a little in a bit.
Yeah.
Can you summarize the key findings of the paper?
The one finding that propagates through the entire analysis is the reduction in strokes, in infarcts. And that appeared in the unadjusted analysis, just analyzing the data in a raw way without any adjustments, and in the regression analysis, as well as the propensity matching analysis. And so that ends up having been as robust a finding as one could possibly have, it seems, that the patients who are on the intravenous heparin ended up faring better in terms of infarcts.
Risk of bleeding, especially after craniotomy and aneurysmal clipping, is a major concern in dosing heparin, as you mentioned. Yeah. What were the findings with regards to occurrence of hemorrhage and Dvts in your study?
Well, that's interesting too. In terms of the hemorrhagic complications, there was no difference between groups in terms of hemorrhages related to the interventricular hemorrhages or tract hemorrhages related to catheters placed in the ventricle or post-op hemorrhages or any of that sort of thing. Those were no different between groups. On the flip side, in terms of DVT, this was another important and essentially constant finding throughout the analysis at the different levels, and that is that the incidence of DVT was either no worse in the unadjusted analysis or was reduced in the patients who had the intravenous IV heparin protocol. So as you may recall, the last thought in the conclusion of the paper is even if you don't feel that this is something that you want to treat your patients with in terms of reducing the incidence of stroke or vasospasm-related stroke, just as a way of reducing DVT as prophylaxing against DVT, it seems to be at least as good, if not better, and as safe as the usual 5,000 units TID.
Mm-hmm. That was a great point. I like how in the discussion, the main kind of point you and your team made was that the study at least shows that this protocol is safe. And and you kind of really did a good job of suggesting the benefits, but also kind of stating as a conclusion that the protocol, the main thing we can tell from the study is the protocol is safe. I want to touch on something that you said earlier. In the unadjusted model, the patients exposed to the low-dose intravenous heparin infusion were more likely to have a higher grade subarachnoid hemorrhage, more likely to have a higher Fisher scale, and had a greater instance of radiographic vasospasm.
Yeah.
But they were less likely to have cerebral infarction and delayed neurological deficit, which was a proxy for DCI.
Yeah.
One question I had is, could these findings be in part due to the fact that subtle neurological deficits were less likely to be found in those with high-grade subarachnoid hemorrhages, given their poor exam?
Well, I'm not sure I'm going to answer your question, but there's one point I'd like to make taking off from your statement, and that is that the patients had, seemed to be worse at baseline. But that's only a reflection of my practice. So certainly throughout the years when I've used this, if I have a patient with a grade 1 subarachnoid hemorrhage who is doing well, then I have not historically put them on the IV heparin protocol, so that the lower grades were eliminated by my selection process, wanting to utilize this for the most part only in patients who I thought were at greater risk for bad outcome. So that's how we ended up with the seeming imbalance at the beginning. So we were two neurosurgeons. My partner, Dr. Aldrich, would put his patients on the standard DVT prophylaxis protocol, And so all of his patients went on that protocol. And my low-grade patients tended to go on the DVT prophylaxis protocol, leaving only the higher grade or worse hemorrhages to go on the intravenous protocol.
I will note that these baseline differences in aneurysmal grade, treatment, and Fisher score were also corrected for in the propensity score model. And as you said, the results of decreased cerebral infarction and delayed neurological deficits still maintain with both models.
Yeah.
So also to touch on one of the kind of interesting things about this paper was that the pseudo-randomization for the allocation of low-dose intravenous heparin that occurred in the study. And as you mentioned, that patients, there was a predetermined call schedule, and half the patients, when you were on call, were more likely to receive the intravenous heparin, and when your colleague was on call, they received the traditional heparin sub-Q.
Yeah.
Can you discuss how that allocation best influences the conclusions we can draw?
Yeah, I mean, it certainly introduces a potential bias in that only one of the two of us was contributing patients to one of the arms of the study. Mm-hmm. And I can't get around that. The thing to remember, however, is that, there's another neurosurgeon who works at another institution who has also taken up using this protocol. His name is Rob James. He's now at Indiana University, and he's the one heading up the clinical trial on IV heparin. And he had a paper some time ago looking at MoCA scores, Montreal Cognitive Assessment Scores. And so, none of the patients in that paper were mine. They were, patients from another institution, another neurosurgeon, and there was a favorable finding in that study as well. These are not the highest level of evidence that we would like to put forward. But these are the baby steps needed to get to, the kind of studies that we do in fact want to do. These are, hypothesis generating studies. And now the hypothesis seems worthy enough of serious study that we have a clinical trial ongoing, randomized and so forth, multi-center.
Who adjudicated delayed neurological deficit, and were they blind to the exposure of heparin sub-Q and versus low-dose intravenous heparin infusion?
Yeah, I can tell you without a question that I had nothing to do with it, first of all. Secondly, it was the residents who were also on the paper. There are several of them, and they were blinded, in fact. Yes.
Got it.
Yeah.
And was MRI used to help adjudicate cerebral infarction, delayed neurological deficit?
No, it was a CT scan almost universally. Only rarely did a patient get MRI, and those were not considered in this paper. It was CT scan hypodensities.
Is there anything else with the results that we missed that you wanted to touch on?
Well, there is one question that has sort of been prominent when I talk about this whole process, and that is, why should this relatively small amount of heparin, not much more than what people get when they get 5,000 units sub-Q, why should there be an effect of this when given almost the same amount, a little bit more, but why should there be an effect when given intravenously as opposed to subcutaneously? And that ends up, and I discussed that a little bit in the discussion section, but it's sort of an interesting biological question, right? And my answer to the question, I may be wrong, but my answer to the question is it has to do with the different fractions of heparin and their bioavailability depending on how they're administered. So when it comes to DVT prophylaxis, we already know that low molecular weight heparin is very effective for DVT prophylaxis. And we also know that the absorption from the subcutaneous tissues is better for low molecular weight heparin than it is for the high molecular weight fractions of heparin. So when you put in unfractionated heparin subcutaneously, you'll get effective absorption and systemic levels of the low molecular weight, but you won't get as much of the high molecular weight fractions, okay? And so that's fine for DVT prophylaxis. However, we think that it's the high molecular weight fractions, which are known to be more biologically active, that may be required for the effect that we see in the context of aneurysmal subarachnoid hemorrhage. And we know that those high molecular weight fractions are not as well absorbed, don't enter into the circulation. So it may be that when the unfractionated heparin is injected subcutaneously, the important part, the high molecular weight fractions, are left behind in the subcutaneous tissues, and so don't circulate and aren't able to do their thing. But when they're injected directly intravenously, then they can get into the circulation and do their thing.
One last question I had with the results was long-term outcomes such as modified Rankin scale were not reported. Was there any plan to report these outcomes in the future? Because I know the patients, they had their discharge disposition and their length of stay overall similar. Is there any plan to report long-term cognitive and long-term functional outcomes?
Yeah, absolutely. So in the randomized trial that's ongoing now, our endpoint is MoCA. And I think that that's where this whole approach to managing patients really shines. So we have the preliminary data that I mentioned earlier, and that is a primary outcome of the randomized clinical trial to look at MoCAs in these patients. We're actually doing that now in our patients, accumulating those data. As I mentioned, I have the informal observation, having seen these patients in my office, 6 to 8 weeks later when they go back to work or not. But MoCA is what we're looking at now. There's another interesting aspect that we are looking at and studying, and that is brain atrophy. So atrophy is a major consequence and an important correlate of decline in higher cognitive function and neuropsychological function in these patients with severe subarachnoid hemorrhage. And an early analysis of brain volumes in these patients is suggesting that brain volumes tend to be better preserved in patients with the IV heparin protocol. And that would go along with the better MoCAs and, again, my informal observation of these patients doing better. But if we can come up with an objective measure, which is what we're in the process of doing now, I believe that would be quite exciting.
Sounds good. It sounds like this study is the tip of the iceberg.
Yeah.
I know you touched on this already. Can you discuss the limitations with the study and future directions for low-dose intravenous heparin?
Yeah, well, the limitations are that, it was a single center study. We can't just assume that this is going to apply across the board with other centers and other neurosurgeons. There's also the limitation that it was essentially one surgeon, me, who was responsible for the patients in the one arm of the study. There are two of us responsible for the other arm of the study, as I mentioned. So these are major limitations. They're overcome a bit, I believe, by the relatively large cohort sizes, 230 and 320 or thereabouts, and the fact that this went on for 10 years. This is a 10-year accumulation of patients. So we think that those are relative strengths. But no question that what we need is a real randomized control clinical trial, and that is now ongoing, and we look forward to having the results of that revealed at some point.
I anxiously await the results of the clinical trial as well. And for me, it was very informative to read the paper, and I learned a lot about intravenous heparin, about both the pharmacokinetics of it and also the rationale for using it IV versus subcutaneous, like you said, and also basically the safety profile that actually wound up having a good safety profile at a low dose. Is there anything else, Dr. Simard, that you would like to leave the audience with? Well,
I think we've hit the high points. I'll tell you, I no longer have equipoise on this question. So all my patients that I operate on, assuming they're modest to high level subarachnoid hemorrhages are going to get heparin. And I have a lot of thank you notes and Christmas cards from these people that I'm very proud of.
It's wonderful. It's wonderful.
Yeah.
All right. Thank you so much. Take care, Dr. Simard. Thank you.
Now in its fourth version, the Emergency Neurological Life Support Certification course focuses on improving care during the critical first hours of patients with acute neurological emergencies. ENLS demonstrates a collaborative, multidisciplinary approach and provides a consistent set of protocols, practical checklists, decision points, and suggested communication to use during patient management. The The ENLS course is designed and accessible for all practices, from physicians to residents and everyone in between. The course can be taken exclusively online, or you can attend a live instructor-led course in your area or at a conference before completing the online certification. To learn more about ENLS certification, please visit www.enls.neurocriticalcare.org and use promo code PODCAST for an extra 10% off your purchase.
Thanks for listening to the NCS Podcast. The NCS Podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Tariq El-Maghribi, Andrew Barishmet, Leonid Groisman, Atul Kalanuria, Lauren Kaufman, Cassie Cronfield, Holly Ledyard, Lindsay Marchetti, Alexander Reynolds, Lucia Rivera-Lara, Jon Rosenburg, Jason Siegel, Zachary Threkold, Teddy Yoon, and Chris Zammit. Our administrative staff and senior producer is Bronnie Rousseau. Music by Mohan Katapali from the University of Miami Division of Neurocritical Care. If you like our show and want to learn more about us, check us out on Twitter, Facebook, or LinkedIn. The NCS Podcast is available on NCS On Demand, iTunes, and wherever you get your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.